Hello, and welcome to The Only You, simple talk about complex topics in psychiatry and mental health. I'm Barbara Amezcua-Patino, psychiatric nurse practitioner with a doctorate in mental health. We are here with our resident doctor, my father, Dr. Lauro Amezcua-Patino, a board-certified psychiatrist specializing in adult, forensic, and adolescent psychiatry. Today we're going to discuss some mental health topics and mental health in general and translate them from pretty technical jargon into something we can all relate to. So, hello.
Thank you, Barbie. Welcome back.
So, what do you want to talk about today? How about we, do you have a topic you want to talk about?
Well, I mean, something that comes up quite often and that is basic in terms of how people relate to us is kind of the lack of understanding of what psychiatry is all about.
Okay.
Right? I mean, I don't think that most people really know or want to know what psychiatry is about. And that is because I think that there's this stigma associated between psychiatry and craziness. So people don't want to think of themselves as being crazy.
Okay.
So they don't want to go to a psychiatrist, right?
So what's the difference between a psychiatrist and a psychologist?
Okay, is to make it simple, psychiatry is part of medicine. It's a specialty of medicine.
So you are a doctor, a physician.
So before being a psychiatrist, you have to be a medical doctor.
Okay.
And then you become a specialist in psychiatric issues, but it has to do with the management of psychiatric illness, right? Psychologist has a lot in common with psychiatry in terms of how they manage and treat abnormal behaviors, but they also have a lot to do with normal behavior. And then psychology has a lot to do with people relations and how they interact with each other, how they relate to each other. So psychology is actually more general in terms of the dealing with behavior in particular, okay, in society in general. Okay. Now, what most people really understand is that psychologists don't prescribe because they're not physicians.
Yes.
And psychiatrists do prescribe.
Yes.
And there are other prescribers in psychiatry that are not necessarily physicians, like you or a physician assistant that works with a physician. They're also prescribers. So prescribers in psychiatry, people who prescribe medications, are not only physicians. They're also nurse practitioners or physician assistants. Another part that I think is kind of problematic is that because we prescribe, most people think that that's all we do. And no, we are a specialist on mental illness. We're a specialist on identifying mental disorders. And we're a specialist on developing treatment that has to do with biology, which is medications, right? That has to do with psychology, which means therapy. And it has to do with their social life in terms of their environment, their life with their family, their children, their church, everything that has to do with interaction with other humans.
Yeah. So, okay. So we've got the psychologists, and then we've got psychiatrists. And we also have, in the psychiatrist category, we include nurse practitioners, PAs, which are physician assistants. And so we've got all of you guys together. And you guys can prescribe medication. And those medications include antidepressants, mood stabilizers, all of these things that help treat psychiatric illness.
Well, psychiatric symptoms.
Right. We've gone over that.
Exactly, because psychiatric illness is much more complicated.
Right.
Now, because we're so connected with medication, people think, well, I'm going to go and get medications from a psychiatrist. In medicine in general, before you get to the medications, you have to do an assessment.
Okay.
We have to evaluate biologically, psychologically, and socially so we can have a diagnosis.
Okay.
Right? And in the diagnosis, we have to include the symptoms the patient is having, how they're suffering, what is happening in the life, and what is happening in the social environment. And we put all those, it's like putting those things in the blender and they come out with, okay, this is what we have.
Mm-hmm.
But most of the time is what we think we have. Because assessment and psychiatric diagnosis, as far as I'm concerned, is always a work in progress.
So what does that mean?
Well, that means that we're constantly evaluating. So when the patient, let's say a patient comes in, I comes in with symptoms of depression, right?
Mm-hmm.
And I evaluate the patient. I say, you do have depression, but you also seem to have a bad marriage and you have a bad relationship at work. Okay. So in order for you to be balanced, we need to do something here, here, and here. Medications, some counseling, some social rehabilitation type of thing so you can function better at work, right? So what it means is that eventually, okay, the patient needs to come back and we need to reassess. We have to evaluate again. Most people think, well, I'm going back to the psychiatrist to get a refill on my medications. We're doing a little more than that. We're actually looking at how things have changed, how things have improved, how things have gotten worse. And then we can say, well, by the way, you came in with depression, but you don't seem to be as depressed, but now you're worrying too much. Maybe you also have a problem with anxiety. It seems to me that your relationships at home are getting worse, and that may be impacting these issues. So you may need to increase this. So we're going to say that you have a marital conflict too. So we're constantly reassessing, but that's what we do in medicine in general, right?
Right.
Things change, things get better, things get worse, new things come up. So we have to make sure that we're constantly reassessing. It would be too easy, right? You have depression, take an antidepressant, you come back and refill it again.
Everybody's fixed, no problems, no changes. Yeah.
So we're constantly in a dynamic process.
Yeah.
So psychiatry really, in terms of doing an assessment, an evaluation, and determining if you have a problem, we're really like movie producers. We write movies, right? We actually look at from the time they're born to now what has happened. Then something happened and things changed. So this chapter of the movie looks different than the chapter we had before.
Yeah.
So why does it look different? What is it intense and frequent? And how do we look at that movie? And when I talk to my students all the time, I tell them to think of movies. Think about how in your mind, if I tell you a story, you can picture it. You can actually get an idea of what is happening in this situation.
Right.
So you can give the patient something back.
Right.
So psychiatry is also not only about diagnosis and assessment, but it's about giving patients something back, options.
Yeah.
Right?
What about patients that come to you and, they're very interested in assessment, your diagnosis, they want, your input and your opinion, and at the end they say, I don't want any medicine. What is your take on that? Is that valuable? Why would a patient even want to come see you for that?
That happens frequently, and especially since I see children, it happens frequently with the parents of children who in adolescents who don't want their kids to take medications.
Yeah.
My take on that is that number one, it is our responsibility to do a couple of things. One is to not judge, right? And that actually has a history back to psychoanalysis and Freud and all that wonderful stuff that actually had some positive, not totally positive, but some positive, in that told us don't judge. It's not your job as an evaluator or a psychiatrist or a psychologist to make judgments. It's your job to understand, number one. Second, we have to respect, right? So understanding and respect to the person who is in front of you becomes the initial tool to have a relationship. Because it's not about me giving them an answer or a solution. It's establishing a relationship that is going to give him options. And I keep coming back to options because patients need to find some answers and they have to make their own choices.
Yeah.
Back to the only you, right?
Yeah.
So when a parent comes and says, or a patient comes and says, uh, I just don't want to take medications. I've heard a lot of bad things about medications. They don't help anything. And there's a lot written out there about how medications are evil and whatever.
Yeah.
I tell them, like everything in medicine is about how much and how often. So if a patient is having so big of a problem, right, that they're terribly dysfunctional and they're not able to go to work, I would say to them, I respect you not wanting to take medications, but I think your problem is severe enough, okay, that you should reconsider. If you don't want to reconsider, there are other options like therapy, family counseling, if they have a substance abuse problem, chemical dependency counseling. There are a lot of things that can be done. But that is no different, and I keep going back to diabetes because I love that illness, because it allows me to compare to psychiatry. If you go to the emergency room, right, and your blood sugar is 600 and you're going into ketoacidosis, and you tell the doctor, I don't want insulin. But the doctor will say, well, I respect that, but you may die.
Yeah.
Okay? So everything is about the circumstance that is in front of you. So there's no one formula that you can say, I always treat these patients this way. It's individual. And that's what in our business we call individualized treatment. We have to tailor the treatment to the circumstances of that particular person, right? In terms of what do you need. Now, if somebody comes in and the blood sugar is 170, and they only want to do diet, okay, go and do your diet. We'll see you back in a couple of months, see how things are progressing. But you cannot hide the urgency. In psychiatry, we forget that our patients are in danger too.
Right.
So how are our patients in danger? Well, they're basically danger to self, danger to others, all distorted thinking, right? Which are the reasons why most people end up being hospitalized.
And in those circumstances, things are very different.
Well, they're not different, they're intense, right? Because you see, you can be depressed to the point of saying, I feel so bad that I don't think my life is worth living, right? That's different than somebody saying, I'm going to kill myself.
Yes.
Right? But we have to take them all seriously. And one of these days we'll do a podcast about suicide in particular. But the reality is that we have to take their risk seriously. No different than somebody going to the ICU with a heart attack. And parents ask me this question frequently. Is my child going to commit suicide? Right? And I have to say, I don't know.
We can't predict suicidality.
But we can determine risk.
Right.
And there's where us knowing about the patient helps us say, I don't think that you, I can't tell if you're going to have a heart attack, but I can tell you a risk of it if you don't lose weight, if you don't exercise, if you don't stop smoking and stop drinking, you are at risk of having another one. It's the same in psychiatry. If you don't take care of your mental health, if you don't take your medications, if you don't stop using drugs and chemicals like alcohol, then you have higher risk. Yeah. So our job is not to necessarily prevent things, is to reduce risk.
Right.
And giving the patient the tools so they can reduce the risk.
Yes. Do you feel that medications are a good tool as opposed to therapy, or do you feel that the combination? Tell me about what the research shows about combination versus one versus the other. Can you explain that combination?
Yes. It's complicated. It's complicated because research usually looks at very narrow issues. It doesn't look at wide issues. So, for example, if you look at studies in depression,
Yeah.
comparing antidepressants versus interpersonal therapy,
Right.
or antidepressants versus cognitive therapy. You're going to see very similar results.
Yeah.
But this population, I do research myself, people in research studies are like from a different planet. And not because they're weird, but because they can only have one thing. Right? And that's not the reality. I don't see patients with just one thing all the time.
Exist.
So my job as a psychiatrist is to separate those issues and look at the intensity. How intense is each one of those? So somebody comes in and has depression, has anxiety, okay, has paranoia, and he's got a bad marriage, and they're drinking too much. Okay, so where do I start, right? So I have to start with all of them. So in that context, okay, the patient has all these problems. Would medications help? Yes, to some degree. But are they going to fix the other problems? Probably not.
No.
Okay. Hence, the only you, right? Back to, you have to take your illness seriously, right? Is not something that somebody else can fix for you. So the only you really means that you're in charge. And what I find very useful, and I found very useful in the last 30 years, is to really help the patient, the individual in front of me, whether it's parent or a child or an adult, to have tools. So how do we give them tools that they can use? So that's how I look at therapy, right? I don't look at therapy in terms of necessarily as answering the question of why. I look at therapy in terms of answering the question of how.
Okay.
Right? Because, yes, it's important to know how we got to where we are now, but we don't know how to change it, right? So if we can focus on how do I know that when I argue with my mom, okay, I feel this way and I react this way. You can ask two questions. One is, why do I feel that way? Or how do I learn to do something different? So I have to argue, right?
Yeah.
So I'm a strong believer in training people to exercise options and to take risks. Meaning, I'm going to take the risk of not getting mad at my mom. That's a risk, because getting mad at your mom is very predictable, and it's known, and it's going to be easy, and you know how it's going to end up. So there's nothing new about that. But saying, I'm going to tell my mom to give me a hug, that would be a different thing, right? Because I feel lonely and I feel empty and I feel sad, and all I know to do is to argue with her. So what if I say, Mom, let's not argue, give me a hug?
Yeah.
That's a different thing, right? But people are very afraid. I mean, it sounds so simple, but it's so difficult to do. It's very difficult for people to take those steps, right? Because we're not very good at change. And psychiatric treatment is a lot about taking risks.
Yeah.
But again, I'm going to go back to diabetes. Changing your diet is a risk.
It's not easy either.
It's not easy. You have to do things differently. So you were starting to get into the issue of what we call normal behaviors.
Yes.
Meaning, normal behaviors in general, even though they're adaptive, they're almost addictive. We don't want to change them.
Do you think everyone has their own normal behaviors? Or are you talking about normal for everyone?
Normal is very elusive. It's not easy to pinpoint, right? It's one of those things that you know it's normal when you see it. Now, it's fascinating in our business, in psychiatry and psychology, that we're very good at defining what's not normal.
Yes.
Right? But we're not very good at defining what's normal, especially when it comes to personality, for example, right? And one of these days we'll do a program about just personality disorders.
Oh, no.
Which is one of my favorite topics.
No.
But the issue with normalcy is that it's probably all of the abnormalities in good balance, right? Meaning you can be a little bit of everything when needed, when life requires you to be a little dependent, a little borderline, a little narcissistic, a little whatever, right? A little avoidant, a little schizoid. If you can have all those features and you can use them, okay, as life is throwing things at you, then you can say you have a balanced personality. Because normal personality is not one thing, right? It's a balance of things. But we've gotten very good at measuring what's abnormal, and that's problematic because we tend to label people as being abnormal. And I don't believe that personality disorders are illnesses. You know, I believe that personality disorders are really abnormal manifestations of normalcy.
Oh no. Oh no. I don't want to have that talk.
We will.
Oh no. I don't like this one. Okay, let's talk about testing. Everyone wants testing done, right? But what does testing really show?
You see, there's no testing in psychiatry that is diagnostic of anything.
Yeah, explain that. Why do so many people think testing is so important, the end all be all? It's going to explain my whole life and tell me everything about my life, and here's my diagnosis, and treat me, and here you go.
I think that goes back to the idea of simplifying things, you know.
But when you say it's not diagnostic, what does that mean?
It means that there's not one test that I can do with anybody that is going to tell me what you have.
Okay.
Right?
So what does it tell you?
It guides me into different areas that are more objective. For example, I can do tests that are going to tell me specific symptoms, okay, in comparison to normal populations. And
Normal.
normal meaning that they don't have the abnormal, right? So people have never been diagnosed with anything. So there's a huge group of people out there that don't have anything,
Mm-hmm.
right?
Sure.
And then you have tests, right? And then you compare these tests and see how different somebody is from this group.
Where is that people? Where are those people?
Somewhere, I don't know.
Find them for me.
Universities, I don't know.
Find
whatever.
them for me.
And we'll get back to that because we have a biased presentation of society because of what we do.
Mm-hmm.
I mean, like for example, the other day one of my students was asking me, I've noticed that a lot of the kids are here in the hospital who are suicidal and they've been taken away from their parents were adopted, right? So he asked me, well, are all adopted kids problematic?
No.
I said, no.
What's wrong with your students?
Exactly.
Tell them to stop
So
that.
I had to tell them, listen, no.
There are such things as
Most
stupid questions.
kids who are adopted are perfectly normal. Okay, there's some small sample, like a small sample of population in general, that have other type of issues that don't require psychiatric treatment. So back to the question you were asking me about testing, we have to get into the issue of, okay, if somebody gets a number of tests, let's say one test that is going to tell me about psychiatric diagnosis, one test is going to tell me about cognitive deficits, one test that is going to tell me about personality profiling. And there's some overlap between the tests.
Yeah.
Or I can go as far as doing a brain map, for example,
Mm-hmm.
right? Each one of those pieces are pieces of a puzzle, right?
Uh-huh.
But the big puzzle is really the history. Is really the movie that we were talking about
Right.
before. So we have that movie, and now we have some objectivity, and we can narrow it down to some degree. But you see, humanity behavior is not static. It's constantly changing, right? So we can't. I'm very concerned about somebody's being labeled, right? So somebody said, he's a schizophrenic.
Mm-hmm.
No, he's a human being that happens to suffer from schizophrenia. And that's what people have fear of, that you're going to be labeled.
Yeah.
That they're going to come to the psychiatrist, they're going to say, you are this. And it's very important to understand and to pay attention to the fact that words have meaning. That we don't label people and we don't change their humanity because they have a diagnosis.
Oh.
So diagnosis is something you have, it's not something you are. And that's important for people to get in their heads they're going to go and see a psychiatrist. Not to be asking for, give me an answer for my humanity, okay? But to answer, is there a possibility that I have some disorder that can be treated, okay, in the context of being a normal human being,
Right.
right? So that balance, I think, is important. It's important for people to hear, you're normal, you have a problem, and instead of hearing, you are a problem. And most psychiatric patients end up believing that they're a problem, and that's sad, and that reflects on our lack of empathy, and we wanted to be technicians in diagnosis versus being people who understand, right? So it's not about us being technical, I mean, I can tell I hate DSM-5. I hate DSM-4 and DSM-3. I hate that book because to some degree...
So what is DSM for
it's
the
called,
people that don't know?
It's called the Diagnostic and Statistical Manual of Mental Disorder. It's a book that is in its 5th edition.
Mm-hmm.
It was developed in the late 50s, early 60s with the first edition. It's changed a lot over time.
Yep.
Probably 20 diagnoses in that book are well scientifically known, okay, that we can say major depression, OCD, panic disorder, anxiety disorder, schizophrenia. They're real well-defined disorders. The rest of them are a consensus diagnosis. It's an agreement among professionals so we can speak the same language. But because I do forensic work, very often people try to put you in a corner and say, the book says this. But if you really read the book carefully, especially the beginning of the book, it tells you that it's not a diagnostic book. It's a consensus book, okay, so we can speak the same language.
Yeah.
And unfortunately, we end up with a lot of people wanting to get the book, okay, and look at 5 symptoms that this is what I have, and it takes a lot of training to understand the humanity of someone. Okay, anybody can read the book and say this is what I think I have, right? But there's more to the humanity of the person than what the book says, and it is important that we give that message to people, right? That you're not here for me to tell you, okay, what you have to do. You're not here for me to tell you what you have. You're here for me to help you understand yourself and to get some options into how to manage your life. Most of the time, less destructively, right? Because at the end of the day, it's about 2 things. It's about the patient being functional and not destructive. Content, let's say.
Yeah.
Everybody wants to be happy. For some reason, nobody wants to be content.
No. The thing is, though, patients want to know. They want a diagnosis. They want a label for themselves. I don't think it's for society, but at least I think, or at least I get that a lot from my patients, that they want to know, well, what is my diagnosis? And they want to know, what are you treating me? And I try and remind them that I'm treating your symptoms. It doesn't matter what your diagnosis is. I have to put it on your records. But at the end of the day, the diagnosis really doesn't matter. But they do find it important.
Different people have different motivations and reasons to want to have the label, right? And we can explore all kinds of different possibilities. I think that you're correct on the patients want a simple answer.
Yeah.
Okay. For a complex problem that's very first world, if you may.
Yeah.
That tell me what I have, fix it, and I move
Yeah.
on. And I think that we need to help people grow, right? There's one issue that humans don't handle very well. We humans. It's not just humans. It is called uncertainty.
So absolutely. I think a lot of our patients struggle with just not knowing and that inability to, deal with that uncertainty, like you mentioned. So
yeah, well, you see, let me give an example. If why some people stay in painful domestic violence relationships, right? Because the known, even if bad, is better than not knowing.
Mm.
And some people feel comfortable in their bubble of misery. So part of our job is to help people walk out of that bubble of misery. Whether they're there because of biological issues, psychological, or social issues, we have to picture them inside of that bubble and let them know you're in there, you don't want to get out of there. Okay? Not consciously. It's not that they wake up in the morning and say, I'm miserable, I'm not going to get out of here. They don't know any better. They don't know any other way of doing that. So when you present it to the patients in that sense, they start understanding, I really need to at least take a peek outside of the bubble, right? And see what's out there and see if I can start taking some steps.
Right.
So again, how versus why.
Right.
Right.
Wonderful. Well, thank you very much.
Thank
This
you.
was a wonderful talk today.
And I'm looking forward to the personality disorder.
No, I can't do that one. No, I can't talk about you the whole time. Sorry. Thank you for joining us today, and we'll see you next time on The Only You.